Is there a point where oxygen delivery becomes inadequate, forcing the body to switch gears into survival mode? Absolutely. And that point is called the anaerobic threshold. This concept is not just for athletes. It plays a crucial role in anesthesia and can be the difference between smooth sailing and serious complications during surgery. The anaerobic threshold is the moment during physical activity when your body can't supply enough oxygen to keep up with its needs. When this happens, your body switches from using oxygen, aerobic metabolism, to a backup system that doesn't need oxygen, anaerobic metabolism, which causes a buildup of lactate. In anesthesia, hitting this point can be a big deal, as it can affect a patient's safety and the overall outcome of the surgery. Let's break it down. You've got VO₂, which is how much oxygen your body is consuming, and DO₂, which is how much oxygen your body is delivering. Normally, these two rise and fall together. But when oxygen delivery, DO₂, can't keep up with the demand, VO₂, you cross the anaerobic threshold, and your body starts to rely on anaerobic metabolism. This point of imbalance is the tipping point where oxygen is no longer sufficient, and the risk of complications increases dramatically. Certain patients are more likely to reach their anaerobic threshold during anesthesia, increasing the risk of complications. These include cardiac patients, where reduced cardiac output limits oxygen delivery, making surgery riskier. Pulmonary diseases such as COPD and asthma impair oxygen exchange, increasing vulnerability to oxygen shortages. Anemia leads to low hemoglobin, reducing the blood's oxygen carrying capacity and pushing patients closer to the anaerobic threshold. In cases of major blood loss, oxygen delivery drops quickly, heightening the risk of anaerobic metabolism. Sepsis compromises oxygen use, making anaerobic metabolism more likely. Lastly, obesity increases oxygen demand, while less efficient respiratory and cardiovascular systems lead to higher risks. Recognizing these high-risk patients helps anesthesiologists adjust management strategies to prevent complications. Monitoring the anaerobic threshold during anesthesia is crucial for preventing tissue hypoxia. Several tools help anesthesiologists stay ahead of this transition. Arterial blood gas analysis provides valuable data on lactate, pH, and bicarbonate levels, with elevated lactate or decreasing pH signaling the onset of anaerobic metabolism. Mixed venous oxygen saturation monitoring reflects the balance between oxygen consumption and delivery, and a drop below 60 to 65% suggests that oxygen delivery is insufficient. Near-infrared spectroscopy allows for real-time monitoring of tissue oxygen saturation, especially in the brain, helping to detect early signs of regional hypoxia. Capnography measures end-tidal CO2, which can indicate metabolic status, with a sudden drop suggesting reduced cardiac output and oxygen delivery. While pulse oximetry continuously monitors arterial oxygen saturation and isn't a direct measure of the anaerobic threshold, it provides early warning signs of hypoxemia. Additionally, continuous lactate measurements offer real-time insight into whether a patient is entering anaerobic metabolism, which is particularly useful in high-risk or complex surgeries. These tools together help anesthesiologists ensure patient safety by preventing oxygen shortages during surgery. So, how do we manage that? Let's break it down. The first key area we focus on is maintaining adequate hemodynamics. Without proper blood flow, oxygen can't get where it needs to go. Here's how we handle that in the OR. Fluid management is essential to keep the heart pumping efficiently. If the heart doesn't have enough volume to work with, it can't generate the cardiac output needed to supply oxygen to tissues. This is why we carefully balance fluids during surgery. For patients with weaker heart function, we turn to inotropic support medications like dobutamine or milrinone. These boost the heart's ability to pump blood effectively, helping maintain oxygen delivery to the tissues. When blood pressure dips, we often need vasopressors like norepinephrine. These drugs tighten the blood vessels, ensuring we keep the mean arterial pressure, MAP, high enough to support tissue perfusion. Next, we need to optimize oxygenation, ensuring the patient's tissues are getting enough oxygen. Here are a few strategies we use. First, we fine-tune the patient's ventilation settings. We might need to increase the fraction of inspired oxygen, VO₂, or perform recruitment maneuvers if the patient is struggling with low oxygen levels. The goal is to keep oxygenation above 60 millimeters of mercury to avoid any hypoxic episodes. In cases where blood loss or anemia are a concern, we consider blood transfusions. Maintaining a healthy hemoglobin level is crucial because hemoglobin carries oxygen to the body's tissues. If there's not enough, oxygen delivery suffers. Another big factor is monitoring anesthetic depth. If anesthesia is too deep, it can cause the blood vessels to widen and reduce cardiac output. We use tools like BIS monitors to make sure the patient is receiving just the right amount of anesthesia, not too little, not too much. Let's not forget about temperature management. Keeping the patient warm is critical because hypothermia can cause the blood vessels to constrict, and it also shifts the oxygen dissociation curve, making it harder for oxygen to reach the tissues. That's why we use warming devices to maintain a normal body temperature. Finally, we have metabolic management. It's important to correct any acid-base imbalances that could affect oxygen delivery and utilization. Acidosis, for instance, can push the patient toward anaerobic metabolism. We also keep a close eye on glucose levels because hyperglycemia, or high blood sugar, can worsen outcomes in critical patients. So, those are the key strategies for managing the anaerobic threshold during anesthesia. It's all about staying proactive, maintaining hemodynamics, optimizing oxygenation, monitoring anesthetic depth, managing temperature, and addressing metabolic imbalances. By doing this, we can prevent tissue hypoxia and improve patient outcomes in the OR. Thanks for joining me on Optimal Anesthesia. For more in-depth information and the latest evidence-based practices, head over to optimalanesthesia.com. Until next time, stay ahead of the curve and keep your patients safe.